I assume people will be filtering over from the hospital. Again, apologize, like I have every week, about the auditorium not being completed. And just to really confuse everyone, next week we need to have grand rounds in the multi-purpose room because this room will be used by a big nursing conference that we hold every year. So I apologize. Does anyone have a safety story? Maybe something from the OR? Doug's like, Joyce, you do this to me every year. Look at me. Every week. Yeah. Anything? He always has one.
I've got one just for quick situational awareness. This week we had a case where an anesthesiologist in low light conditions reached for a syringe to give what he thought was calcium, and actually turned out it was epinephrine. Fortunately, we're on bypass, so it didn't make a difference. But what we became aware of is actually there are multiple drugs that look the same in the cart, and the way the cart's organized, it's pretty hard to distinguish them, so it's going to prompt a reorganization of the cart. So,
good story. Thanks, Doug. So welcome everyone watching online. Hopefully you can hear me. So our speakers today, we're very lucky to have them both here today to speak with us and here at University of Utah and Primary Children's Hospital. Dr. Michael Rollins is a graduate of the University of Tennessee College of Medicine. He completed his residency in general surgery here at the University of Utah and subsequently his pediatric surgery fellowship at Washington University School of Medicine. Although Dr. Rollins' practice includes the full breadth of pediatric surgery, has special expertise in the treatment of patients with anorectal malformations and Hirschsprung's disease. He's the founder and director of the Pediatric Colorectal Center at Primary Children's Hospital, as well as the co-founder of the International Pediatric Colorectal and Pelvic Learning Consortium. And we've been happy to have him here since 2007, I'm told. Is that right? Great. Dr. Justin Wheeler is a graduate of the Ohio State University School of Medicine. He completed his residency at Phoenix Children's Hospital and subsequently his pediatric GI fellowship at Cincinnati Children's Hospital and Medical Center. Justin grew up in Utah in the Cache Valley. We're happy to have his brother here, who's an architect, he tells me, but not involved in our auditorium remodel. And Dr. Guthrie, who is at the NIH today and couldn't be here, sent me a note saying we were thrilled and lucky to recruit Justin here to the University of Utah and Primary Children's in 2017. So along with Dr. Rollins, Dr. Wheeler established one of the few pediatric intestinal motility centers in the Western United States, and we're thrilled to have them talk to us today about motility disorders.
Great, thank you for the introduction. So today the title of our talk is Medical and Surgical Management of Gastrointestinal Motility Disorders, and what to do when the bowels won't budge had nice alliteration, so I threw it in there. Try that again. Okay, so as far as disclosures, we don't have any relevant disclosures or conflicts of interest in relation to this presentation. The objectives today are just to look at the causes or etiology of common GI motility disorders, indications for referral for motility evaluation, discuss evidence-based strategies for diagnosis, and then review some of the treatment options. And we'll also be introducing Primary Children's Hospital new motility disorders program. So the professional practice gaps are listed here, just coming up with diagnoses for uncommon and common motility disorders, management strategies, and highlighting surgical interventions. And some of the results that we're hoping for is just coming up with a good differential for feeding and evacuation disorders, understanding what motility testing is, what is this all about, and the medical and surgical treatment options, and what a failure might look like. So objective one, the etiology of motility disorders. I'm going to pepper in a few just GI tract party facts that you guys can pull out if you need to. So here's one. This is actually good for clinicians. The enteric nervous system, the nervous system of the belly, has 500 million neurons, and that's about the same number in a dog's brain or two cats' brains. So if you're ever explaining why your patient is having abdominal pain, you can talk about the two cats having a fight in the belly or the dog. So what is motility? You know, this is something that maybe not everyone's familiar with. You know, the idea of motility refers to just the movement of nutrition and liquids through the digestive tract and then coming out the other end. And it's this finely choreographed dance of moving food from the mouth all the way out to the toilet. And there's many steps along the way. And usually we talk to patients that once they swallow, they don't think about it until they get the urge to visit the toilet. But a lot of things happen in between, moving through the esophagus, stomach, the small bowel, and the colon, and ultimately the anus. And disorders are a varied group, motility disorders, a varied group of diagnoses that is a disruption in any step of this process. And it can be to a variety of causes. It can be due to problems in muscle, connective tissue, or the way the nerves work. So defining normal is an important step. First of all, the tract is just a long tube is what we talk about. It's 1/4 of a meter long in infants approximately, and can be up to 9 meters in adults. And it's mostly made of smooth muscle. And usually at baseline, it's partially tensed. And then we get peristalsis when you get synchronized contraction and relaxation along that tube, pushing food and liquids along. And it can take anywhere from about 1.5 to 3 days normally, from ingestion to digestion, or instead of from farm to table, I'd say from table back to the farm. So what is normal function for each of the different parts? So I threw up here the job or the function of each part of the GI tract. The esophagus, its only job really is to stay empty. It's a conduit from the mouth to the stomach. It's usually pretty good at it. The stomach does these things that we're familiar with: mixes, sanitizes, stores, digests. The small bowel absorbs, and the colon absorbs water and also acts as a receptacle for or storage place for waste. This is the average time that it takes to get through each part of the GI tract. So 6 to 15 seconds after a swallow, it hits the stomach. The stomach usually hangs out for, when we do gastric emptying scans, on average it should be about halfway empty within 2 to 3 hours, and by 4 to 5 hours it generally is 100% empty. The small bowel is not a place for things to hang out for too long. It usually moves through pretty quickly, 1 to 2 hours on average by the time it hits the colon, and can be as fast as 30 minutes, take as long as 3 hours in studies of normal individuals. And the colon is where the prime time happens for things that we eat, so hangs out there for a lot longer. 40 hours for adults on average. Interestingly, males have quicker transit time than females. One study, they showed 33 hours for men and 47 for women. And in pediatric patients, it's generally about 29 hours. Infants are much shorter times. So what might change motility? There's a lot of things up here, huge list. And diet, illness, stress, not moving, just being constipated slows down things upstream. Dehydration, surgery, medications, PPIs. As a GI doctor, we've been talking about the effects of PPIs, what it can and can't do, and maybe some negative side effects. And this is just one more to add on to the list, is it can slow down motility. And then the behavioral aspects. Regurgitation can send things going the wrong way up, called rumination, or else it can send, withholding can slow everything down. What are common symptoms then of motility disorders? And you look up here and you see there's a lot of them. Dysphagia, difficulty swallowing, abdominal pain, nausea, vomiting, distension, growth failure, constipation. Many of you are thinking every single patient I see in my clinic has a motility disorder, because these are very nonspecific. And teasing that out and deciding which kids might benefit from testing is an important part of my job and all of our jobs. So what are some examples of motility disorders? I'm going to go through each of the different kind of body parts, body groups, and highlight some of the more famous ones. So in the esophagus, a common one is achalasia that we like to talk about in motility. And here's a picture, the one from maybe you saw on your PEDS boards, of the bird beaking, a dilated esophagus, and a narrowed, very narrow exit through the lower esophageal sphincter. In abs, it's a problem with nerves and also muscles. So other ones are eosinophilic esophagitis, an allergic condition. It actually can alter motility in the esophagus. And then inflammatory or sclerosing things like Sjogren's or scleroderma. The small bowel, you can have things like gastroparesis, where the stomach just doesn't squeeze, pseudoobstruction, mitochondrial disorders, gastroschisis, or other congenital abnormalities of the bowel, or even injury, so neck and resulting in short bowel syndrome, can all alter the way the GI tract works. And I put some colors up here, tried to avoid green in red for the colorblind out there, but highlighting here the different causes of these types of motility disorders. So you can see that sometimes there's multiple things contributing to why a patient might have abnormal motility, whether it's nerve or muscle, connective tissue, or combination of all three. What about further down the GI tract in the colon? So constipation is probably one of the biggest and most difficult ones that we might see on a routine basis. Encopresis or soiling. And then other causes like tethered cord, spina bifida, Hirschsprung's disease. This is a really interesting image here. This is an untreated patient who had Hirschsprung's disease. This patient lived in Philadelphia, and in his colon, megacolon, is on display at the Mutter Museum. They actually sell a plushie of that colon. You can see there. If you ever make a visit, I'd highly recommend dropping by this museum. A lot of interesting medical oddities and this interesting case of Hirschsprung's disease. And then in the anus as well, there can be problems, things like dyssynergia, achalasia. And you can see that each of these things can have multiple contributing factors, whether it's the nerves or the muscle. So objective 2, talk about indications for referral for motility evaluation. When might you do this? Here's our GI tract party fact. The first endoscopy was actually performed by the famous Dr. Kuzmal, who you might be familiar with his breathing pattern, abnormal breathing pattern paid after him. It was a very rigid endoscope, and so they used a sword swallower to do it. So when do you refer to motility? So patients with GI symptoms who are not responding to routine management would be the ones that would benefit from a referral. Typically, we'd say if you have GI symptoms, refer to Peds GI. And Peds GI providers or other subspecialists like maybe complex care or surgical providers, they might pursue motility testing after other etiologies have been ruled out, such as an anatomic, inflammatory, allergic cause. I'm going to highlight this a few times during this lecture. Motility testing is not indicated in the majority of patients. So many patients who have refractory constipation do not need necessarily some of the testing that I'm going to talk about. So when might you refer? So indications would be dysphagia, so severe recurrent food impactions or pain when swallowing, refractory feeding intolerance, so weight loss or vomiting, and refractory constipation, failed routine constipation management. And so what is failed constipation management? Dr. Rollins will highlight this a little bit later as well, but it's just a persistent presence of symptoms despite being cleaned out and using a daily stool softener or laxative. For anyone who wants a good reference, you might be familiar with this, but the Primary Children's Hospital Foundation, along with the GI division, put out this great video. Dr. Deneau, Mark Deneau, put it together, and it highlights the causes of constipation and encopresis, how to do a clean out. It's great for families and for providers, and it stresses the importance of keeping stools soft and behavior modification. So if you're looking for a definition, if they've already tried this and they're not doing so well, then for sure send it Peds GI and can ultimately come along to motility if needed. So how do we diagnose motility disorders? What do I do here is, in this new clinic that we've developed, this new program? Here's the GI tract party fact. Interestingly, the colon can generate more than 200 millimeters of mercury worth of pressure when it contracts. So when we're doing our studies today, I'll show those off, show that, but it does maybe help you understand why these kids that are constipated and have hard poops, why it hurts so much when you have 200 millimeters worth of mercury of pressure, like a blood pressure cuff squeezing. So how do we diagnose these? There's some routine ones that we're all familiar with: X-rays, enemas, esophograms, something called a Sitzmark test or gastric emptying scan. These can all help us understand if there's slow or delayed emptying. This is an example of a Sitzmark study. It's just this little pill that you swallow that has radio-opaque rubber bands in it, and it's kind of a poor man's motility test, so to speak. You swallow the rubber band, you take a few X-rays over the subsequent days, and you can identify if there's a region of their colon that just isn't squeezing, or if it's collecting in the rectum that might signal maybe some behavioral withholding, or else if they're all gone and the patient's saying they're not pooping, you might have a patient who might be not completely forthright or honest about what's going on. You can also use endoscopy or surgery, taking biopsies to diagnose Hirschsprung's. That's the gold standard. And then we can do manometry. So manometry is what I'm going to be highlighting for the next, the main portion of the remainder of my talk. And I'll be talking about catheters, specifically manometry testing, where we use catheters to do this. There are also other newer modalities that aren't necessarily ready for prime time in pediatrics. There's a wireless capsule that they use in adults, and there's a type of testing called EndoFlip, which is we are just starting to roll out here at Primary Children's as part of our esophageal clinic that can also be used for motility testing in the esophagus. So manometry, what does that refer to? So manometry is just the measurement of pressure. It's squeeze. Think of a stress ball. As you squeeze down, you're exerting a pressure. Same thing happens in the GI tract, and that's what manometry is. You're just studying pressure. And we use catheters to do that. So they measure the organization, the duration, and the strength of contraction and relaxation. And you can see here the computers that we use and then one of these catheters. And you can look for abnormalities in nerve, muscle, or both. And we'll look for absence of contractions, weak contractions, or disordered contractions. And there are 4 different types of manometry, and each one aims for a different part of the GI tract: esophagus, intraduodenal, which we also call AD, colonic, and then anorectal or AR. And you can see here, this is a simplified old school version of what a manometry tracing looks like. It's an analog tracing might have these pressure spikes as food moves along and esophagus squeezes down on the catheter. You'll see a spike in pressure and then a relaxation. So what are these catheters? There are 2 different types that we use here, and there's a system called a water perfused catheter system, and it just has some water that flows through these tiny little capillary tubes. And as the water flows through it, there's transducers that can just sense a decrease in rate of flow or change in pressure through those tubes, and then it converts it into a tracing. It's a little bit of a complicated setup, might be a drawback. The good thing is they're disposable, they're relatively cheap, don't get quite as much data as you do from a solid state catheter. So these are the other kind of catheters we use. These sense pressure change through microtransducers that are spaced along the catheter. It's easy to set up, plug and play. And just plug it in and you can get started. They're reusable, but they're very fragile and they're expensive. So the catheters are more than $20,000 each. And you get more data out of these, but if they get damaged, then it can be costly. So these catheters have improved significantly over the past 10 years, and that's when kind of the motility studies and the world of motility has really started to take off. And it's with the evolution of high-resolution manometry. High-resolution manometry just refers to a lot of closely spaced sensors putting together this continuous set of data that gives you an idea of how the GI tract is working. And this is an example that you see here. It's called a Klaus plot of pressures. You can think of it like you're watching that guy Eubank, I think is his name, that's the weatherman here, and he talks about the high pressure systems, low pressure systems, and that's what we're looking at, like a weather map, high and low pressures. This is an example of an esophageal manometry tracing, and I'll go into a little bit more detail here in a minute, but that's what high resolution manometry does. Gives us lots of data. So I'm going to highlight short cases for each one of these kind of types of testing, when it might be useful. So first of all, we have a 19-year-old female, history of a renal transplant, who has vomiting and dysphagia, has a G-tube, and had this esophagram. And you can see on the esophagram, this is abnormal. This is 5 minutes after swallowing some barium, and you can see abnormal peristaltic waves there instead of a smooth contraction. And then you see almost zero emptying into the stomach. So esophageal manometry might be helpful for diagnosing this patient. So what is esophageal manometry? So it's something that measures the esophageal activity. We look at liquids and paste and cookies, solids, seeing how each of those, the esophagus might respond. It's kind of like an NG tube, about the same size, and it goes down the throat, and it takes about 15 or 20 minutes to do this. It's done awake, and there's kind of standardized swallow volumes. Once we had a patient not show up, and I was curious what this test was like. Made a poor life decision and tried it out on myself. It's very uncomfortable, and so I can kind of relate with the patients, but it is helpful once it's in there. And if a patient is willing to go through the testing and we find something, it's usually worthwhile. And there's a standardized classification called the Chicago classification. It's in its 3rd iteration now, where you can diagnose various esophageal disorders. This is what a tracing looks like. You can see that along the top of the image there's some, the pressure system is the high pressure area of red and green is the upper esophageal sphincter. As you swallow, that sphincter relaxes. You can see that pressure drop. And then the bolus moves down the esophagus. You see the lower esophageal sphincter also relaxing as food drops in. We can use this and the data that comes from it to identify maybe is there a problem with the skeletal muscle, which is up at the top third of the esophagus, or is it transitions down to smooth muscle is the problem down there. And can identify if their dysphagia is due to achalasia or lower poor peristalsis. So our first case, there's high concern for achalasia. So there's 3 types of achalasia, just quick review for everyone who might be retaking boards. Type 1, you get no squeeze and no relaxation of that lower esophageal sphincter. You can see in that image on your left, there's just no squeeze. Type 2, you get these panesophageal all the way along the esophagus pressurization zones, and you can see them highlighted there in green. And then type 3 is just a tight spasm without relaxation of the lower esophagus. Our patient hasn't undergone testing yet, so yet to be determined what kind she has. Case 2 is a 14-month-old female with abdominal distension and chronic feeding intolerance on TPN. Images showed this big dilated loops of bowel without a physical obstruction. So antroduodenal manometry, AD manometry, might be helpful in this case. And that's where a catheter is placed under endoscopically, goes down in the stomach, down into the small bowel, and has sensors all along that can test stomach and small bowel function. And it looks at motility in those regions. It's a 6-hour study. The catheters are placed in the OR and endoscopically. Patients wake up and they're admitted either to the RTU or to the hospital, to the CMU, and let the anesthesia wear off. And the next morning we do these tests. So hook patients up. 6 hours, we look and see what the bowel does when fasting, see what happens when we feed these patients, and then after we give medications that stimulate contraction. So erythromycin or azithromycin, the common macrolide antibodies, those stimulate atrial contractions actually in the stomach, and we use those to see if the stomach is working. And it can also be used as a therapeutic treatment option. Octreotide stimulates small bowel contractions, so we use those two to see if we can get a response. And we look for phase 3 MMCs, which are the migrating motor complexes that we think really push food along through the duodenum and antral contractions. So here's an example. I'm showing you kind of the analog versions in some of the Klaus plots. This is an analog version of a normal tracing. You see here these phase 3 kind of organized patterns of the squiggles up there. That's contractions. Over a 5-minute period, you see this nice linear move. They eat a meal, and then you get the normal phase 1 or the normal fed response with contractions all along. So that's normal. Our patient probably has a tracing that looks like this, where you have contractions that start up above, but at the same time you have contractions moving in the wrong direction. So things just don't move forward, and you have a lot of disorganized activity. And this is what a patient who has pseudoobstruction, a neurogenic pseudoobstruction, might look like. Case 3, 17-year-old female with refractory constipation, has had the kitchen sink thrown at her from enemas to oral laxatives at high doses, the newer ones like linaclotide. All these things are not responding. You can see on an enema kind of a dilated sigmoid rectum. This is a patient where we might use colonic manometry. And this is where we would evaluate the way that her colon squeezes. Is there an area that's not working at all or just not responsive completely? Or is it segmental or is it pancolonic? It's a 6-hour study. Similarly, you place the catheters endoscopically. They go in the hospital. Afterwards, they will have completed a clean out before the colonoscopy, usually in the hospital, because usually these kids are pretty constipated and it takes an NG clean out to make sure that they're nice and clean. We give them bisacodyl after, that's kind of the stimulant laxative. It's given as a liquid typically through the catheter, and we look to see, is that colon squeezing? Do we get HAPCs, or those high amplitude proliferating complexes where the colon squeezes or pushes things along? Usually want at least 3 in a row, show that it's propagating, and you want to see a change of up to 60 millimeters of mercury. So we did our first test just a couple weeks ago, and this is from that test. You can see this patient had HAPCs. You can see the changes in pressure. Those pressures are going up above 200 millimeters of mercury. But this was only after being fed, only had a couple of these, and in general, the whole colon was pretty quiescent, and so consistent with slow transit constipation. You can see the analog tracings kind of there on one side, and then the Klaus plots, which show the same data of those contractions moving along. And then our last case is an 8-year-old, bad chronic constipation on antegrade enema. As you can see a Chait tube there in the picture, the little pigtail curlicue where it gets antegrade enemas, and this child has prolonged straining. We did a Sitzmark study, and you can see, if you look closely, if it shows up there, a whole bunch of radio-opaque little rubber bands hanging out in this child's rectum 3 days after taking the pill. So how might we use anorectal manometry to look at that? This has been around longer, this modality, and is used a lot more, but you basically have a catheter that goes in the bottom and a balloon on the end that can sense pressure and squeeze, and it mimics a stool as you inflate it or deflate it. We use either solid-state catheters, you can see there at the top, and we also are now using this new mobile anorectal device that we can just do in clinic, which is very convenient for families. It's a lot cheaper than having to go doing more of an outpatient procedure in the procedure center, and it identifies good information. Here's some examples of what those tracings might look like. The high-resolution manometry gives you the same kind of Klaus plots, and then that mobile device, this is an example of a tracing as we're doing our testing. So what does anorectal manometry tell us? It looks at anatomy. It tells us about sensation and function. If you have what's called a rare, is the thing that we really look for in the manometry test if we're worried about Hirschsprung's disease. That's an inflation of the balloon in the rectum induces a reflexive relaxation of the anal sphincters, and if you are missing the rare, then it can be indicative of Hirschsprung's disease or anal achalasia. We also can look and see how kids squeeze when they feel something in their rectum. Do they have sensation? And see how well they can push poop out. Can guide management in a bunch of ways. I've highlighted those already. Can also guide interventions if you need to do things like Botox, dilations, or biofeedback. In our case, our patient had dyssynergia. They would try and push. We had them push on anorectal manometry. You can see those top tracings are the anal sphincter pressures, and spikes in pressures as that kid is pushing, where he's contracting his anal sphincter muscles. He's pushing on the gas and the brake at the same time. So trying to defecate, can't get it out, has pain. You see the rectal balloon pressure is indicative of him bearing down or increasing abdominal pressure, and he's just not having effective defecation dynamics. So that's when we can use we can use biofeedback. So this is Katie Blumenthal. Katie is fantastic. She's a doctor of physical therapy at the University of Utah's PT, and she'll actually be coming and joining us here doing a clinic once a week to work with these kids on biofeedback, where they can retrain the brain on how to poop, where they have stickers and they can train them how to relax sphincter muscles in their belly or down below and in their anus. So medical and surgical management options. Here's your party fact. We use senna a lot. It comes from the pea family, in case you're worried. It's been used around the world for cathartic properties. A lot of different management options. There's medicines. There's biofeedback I highlighted. There's endoscopy, dilations, and Botox. This is an example of pyloric Botox, where you have someone who might have bad gastroparesis and you do Botox to relax the pyloric sphincter. And then surgical interventions, which Michael will be talking about when I finish up here. So finally, to finish up my segment of this talk, I want to introduce our motility disorders program. So final GI tract party fact, the average adult makes between half a liter and almost a liter of saliva a day, which is a lot. And that's why those kids that get obstructions and they're spitting into a bag have so much spit coming out when they have those food impactions in their esophagus. Interestingly, they did a study and they looked at when we're asleep, you make almost no saliva. So what is Primary Children's Motility Disorders Program? This was a collaboration of GI and surgery, and it's been with the ample help of the Colorectal Center. It's under their umbrella here, Primary Children's Hospital, a lot of support from them. And it's a collaboration where we bring together lots of providers to help work with these kids who have complicated motility disorders, including physical therapy and social work and nutrition and child life. It gives additional diagnostic and treatment options when routine care has failed. And this is just pictures of the team. The nursing team is probably the biggest part, is along the bottom there, plus our social worker, Christy Gaisford, who has been fantastic. And then Sarah Zobel, the nurse practitioner, she's also the direct, helps manage and has helped put together a lot of the finer aspects of this clinic and has really made it happen. And then all under the direction of Michael Rollins, who's the director of the Colorectal Center. So how do you refer a patient to Motility Clinic? Like I highlighted before, the patients who would benefit from testing are those who have severe dysphagia, chronic feeding intolerance, or severe refractory constipation. Right now, we're limiting referrals to pediatric GI specialists. Patients should have been evaluated by them first, surgery or complex care providers. And there will soon be orders available in iCentra, but for now, we're taking referrals through emails or fax, or else messaging me directly in iCentra, and we pass those along. So in summary, motility disorders, they encompass a lot of varied diseases. They require unique diagnostic modalities at times, and the strategies are varied and really condition dependent. Many children who have the symptoms that we've highlighted don't necessarily need motility testing. We're able to get them better just with medical interventions or behavioral changes. But the motility disorders program, it's open. We're excited to be doing all of these testing, the manometry testing for patients where it's indicated, and I think it's really going to be helpful in diagnosing and managing these interesting and challenging patients. And I'm now going to pass the time over to Michael Rollins, who's going to highlight management options for some of these kids who have specifically incredibly severe and difficult to treat constipation.
Does that work? Okay. Thank you, Justin. We are very excited to have Dr. Wheeler join us. As he mentioned, I'm going to specifically talk about management of severe functional constipation. And in the past, we've basically been operating or managing these children using the force with no real data to guide us. And with the development of these advanced motility testing techniques, I think we're going to do a much better job in helping these children live a higher quality life. I'm the director of the Colorectal Center, as was mentioned. By the way, thank you for the introduction, Dr. Soprano, and the chance today to talk. But the center focuses on care of children with anorectal malformations, Hirschsprung's disease, and functional constipation. And I got to tell you, the functional constipation children are some of the most difficult children to treat. And I think in the past they have been under-recognized potentially and maybe not managed as well as they could be. So the most severe cases are referred to surgery clinic or the colorectal clinic for management. This is highlighted in these two radiographs on the screen. On the left, this is a child with severe impaction of the rectum and sigmoid colon. This child actually required manual disimpaction in the operating room. The image, the x-ray on the right of the screen, is a plain radiograph taken the day after a contrast enema, which demonstrates a megarectum, a rectum filling the entire pelvis, and retention of the majority of the contrast, which to us suggests a hypomodal or slow-moving colon. I also want to mention that in management of these children, I cannot overemphasize the value of a team. Dr. Wheeler highlighted that a little bit in his talk, but we have an incredibly supportive administration. We've got an incredible group of people helping provide care for these children. Sarah Zobel, our nurse practitioner, is the cornerstone of the program, coordinates and manages our clinic. We have 2 nurses, child life specialists, social worker, dietitian, MAs, and a dedicated clinic scheduler. And so it really requires a team approach. Up to 30% of patients who are referred to a surgical clinic will require some type of surgical intervention for management of their functional constipation. So when a patient is referred to our clinic, they're initially considered a candidate for our bowel management program. Now, they will have received stool softeners, laxatives, different types of enemas prior to coming to our clinic. But we have a week-long bowel management program that's a little bit different than things that they've tried before. Now, this is in patients where organic causes or anatomical causes for their constipation have previously been ruled out. And children with functional constipation should have the ability to have voluntary bowel movements. They're born with an anatomically normal anal canal. So the day prior to clinic, we obtain a contrast enema. This helps us look at the characteristics of the colon. Is there a megarectum? Is there global dilation of the colon? It's also cathartic so that they can start their bowel management program with a clean colon. Then they have their clinic visit the following day. We obtain an abdominal x-ray to look at stool burden and retention of contrast, which I've alluded to, and an individualized treatment program is recommended. Depending on the child, the situation, the family goals, this may include laxatives or enemas. And then for a week following this, we obtain a daily radiograph and speak with the family. And based on the patient's clinical and radiographic response, we adjust the treatment program as needed. We consider success when a patient is clean with no stool smear in the underwear. So nothing, not just large accidents, not even a smear. That's our definition of success. The child can wear normal underwear and there's minimal to no discomfort with the medication. And radiographically, they have a clean rectum and left colon, which is demonstrated in this radiograph here. We initially consider patients for laxative treatment, and we use high-dose stimulant laxatives. And these doses are much higher than children have typically been on before, much higher than recommended doses. There are no long-term side effects that have been identified with high-dose Senna treatment. The only consequence is a staining that occurs in the colon called melanosis coli, which has no pathophysiologic consequence. So we typically start with Senna at 2 milligrams per kilogram per day. We arrived at this dose after reviewing a large number of patients in our center and evaluating the final dose that they required to effectively empty their colon. And then water-soluble fiber is often added to keep the stool soft but provide bulk and increase the effectiveness of the laxative. If a child fails laxative therapy due to significant cramping or vomiting with the dose that's required to empty the colon, or they don't empty their colon, then we transition them to large volume enemas. These are administered either rectally or via antegrade route. And for our enemas, we use a balloon-tipped catheter so that it can create a seal and enough pressure can be created to infuse the solution proximally and stimulate the colon to evacuate. The main component of our enema program is saline. We typically start children less than 30 kilograms on about 20 milliliters per kilogram per day, so large volume, much larger than the 160 milliliter adult fleet enema or 60 milliliter pediatric fleet enema. Usually they require the addition of some irritant, so glycerin or castile soap. In review of our experience of 136 children with functional constipation who went through our bowel management program at Primary Children's, we successfully managed over half with laxatives. However, as you'll notice, about 42% of them required enemas to successfully empty their colon each day and remain clean. Our short-term success rate is 86%. We wanted to evaluate the durability of this type of program, so we reviewed patients who had clinical data available 1 year prior to going through bowel management week and then up to, or at least 1 year following our bowel management week. In those patients that we reviewed, 50% of them required at least one hospitalization and many of them multiple hospitalizations in the year prior to going through bowel management for management of their constipation. After going through our program, we noted an 82% reduction in hospitalizations related to management of constipation. 36% of the patients were non-adherent to the program, which again kind of demonstrates some of the difficulties that parents and families may have with the program. But notably, there were no hospitalizations in those patients who were adherent to the treatment program. We wanted to see if this was reproducible, so we collaborated with Nationwide Children's Hospital, who have a very similar bowel management program and a very similar definition of success, and examined our combined experience over a 4-year period. This was published this year in Journal of Pediatric Surgery. So 184 patients who again had data at least 1 year of follow-up. There was a 64% reduction in ED visits and 57% reduction in hospital admissions. So pretty reproducible in another site. In children who fail enema therapy, so you'll kind of notice we're taking a step-up approach, laxatives, enemas, fail enemas, additional testing is needed, additional testing that Dr. Wheeler highlighted previously. And depending on the situation, we may choose a different modality, colonic manometry versus anorectal manometry. Surgical options fall basically into 4 broad categories: anal and pelvic floor procedures, surgical techniques to provide a conduit for antegrade colonic irrigations, or the ACE procedure, as you may have heard about, colonic resection and rectal operations, and then finally, in the most refractory patients, intestinal diversion. There are many issues with interpreting the current literature that is out there. Perhaps most importantly, the literature is filled with single center small series. There's a lack of definition of what actually constitutes medical failure, medical treatment failure. There are highly variable indications for surgery, preoperative evaluations, and surgical interventions. There is no standard definition for success in the literature, and long-term follow-up is severely lacking. There are two procedures that are used, 2 anal and pelvic floor procedures that are commonly used. 1, anal dilations, and 2, Botox injections. And these the indications for these are different, but for children who are diagnosed with internal anal sphincter achalasia, using anorectal manometry, Botox injection is an effective therapy. Now, roughly half of them will not respond to Botox, but again, can be effective. Internal anal sphincter myectomy, which has been recommended in the past for some of these disorders, has been abandoned due to the potential for permanent incontinence. Patients that are considered candidates for an appendicostomy or cecostomy, again, a conduit for an antegrade enema. These are also known as an ACE or a Malone or a MACE. These are children who failed maximal medical therapy with stimulant laxatives, but have been successful in staying clean with a daily rectal enema. This may also include patients who have the inability to tolerate a rectal enema. A relative contraindication is obesity due to the technical aspects of bringing the appendix through a thick abdominal wall. This is an intraoperative photograph of the Malone appendicostomy. In this technique, the cecum is plicated around the base of the appendix. These are silk sutures going through the cecum, appendix, and cecum on the other side. It creates this plication around the base of the appendix, which is an anti-reflux mechanism, so that when fluid is infused through the appendix, it doesn't leak back out. And then the appendix is sewn to the base of the umbilicus. This is a child who's had an appendicostomy created. On the left, the tube is passed through the umbilicus or the appendicostomy, and the enema fluid infused. On the right, after the enema is given, tube is removed, has a cosmetically hidden orifice. Can go swimming, whatever. The other technique is a cecostomy or Chait button. In this technique, a pigtail catheter is placed directly through the abdominal wall in the right lower quadrant into the cecum. And after about 6 weeks, this can be exchanged for what's called a Chait button. The coiled portion is within the cecum, and then the top part, or the button, is flush on the patient's skin. The lid can be opened, an adapter connected, enema fluid infused, similar to giving a feeding through a gastrostomy tube. There are 26 studies that are reported in the literature looking at the effect of antegrade colonic irrigations in children. Only one of these is prospective. The indications for the procedure are unclear. There are variable definitions of success. These definitions range from report of increased stool frequency to less than one accident per week, or only smears in the underwear, to totally clean. However, given those issues, in combination, the outcomes are reported as good in about 82%. However, complete resolution of constipation and removal or reversal of the ACE occurred in only 9.5% of patients. These are three of the largest and the three most recent studies looking at the long-term success of appendicostomies. So small patient numbers, but decent follow-up, 3.5 to 7 years. Success approaching 80%. But notice, only about a fifth of these were able to discontinue use of their appendicostomy in the follow-up period. I think this demonstrates the severity and the chronicity of this problem, and validates our need to follow these kids long term. If children fail treatment with ACE, colon resection and rectal operations are considered. These include partial colectomy with or without an appendicostomy, total colectomy with ileorectal or ileoanal anastomosis, or pull-through type procedure with removal of the rectum. None of these should be performed without guidance from manometry. This is an illustration of a megarectus sigmoid. In the operation, we resect the non-functional, severely dilated segment, and then anastomose the more normal caliber proximal colon to the remaining rectal reservoir. Prior to 2014, there were only 10 studies reporting on 83 children in the literature evaluating the effects of this type of approach. Again, indications for surgery and preoperative evaluation were highly variable. Satisfactory results were reported in 22% to 89%, with a follow-up time period of 3 months to 5 years. Since 2014, there have been two series published in the literature looking at the effects of colon resection. One from University of South Alabama, a decent number of patients, 34. Majority of them underwent rectal resection with a pull-through type procedure. Follow-up was 6 years to 13.5 years, and success rates 60 to 78%. So there's clearly something else going on with these kids besides the dilated segment doesn't work. Get rid of it, they'll be fine. The other series is from Nationwide Children's Hospital. They treated patients with sigmoid resection plus an appendicostomy. Their follow-up is short, 10 months median. They report a 97% success rate. But notice, 9 of their patients continue to require high-dose laxatives, and 21 continue to require daily antegrade enemas. Again, demonstrating the point that something else is going on besides a segment of colon that's not working. Finally, in kids who have the most refractory disease, intestinal diversion can be considered. There's some evidence in the literature that by diverting stool from the colon, it can allow the colon to regain function. Shown here are the two largest series in children examining the effectiveness of intestinal diversion. The first is from Children's Hospital of Orange County in 2001, examining 12 patients who had severe colonic dilation and global dysfunction on manometry testing. They were treated with either an ileostomy or a colostomy and then restudied at 6 to 30 months. Dilation resolved in 11 of the patients. In 4 cases, the motility returned to normal and they simply had their stoma closed. However, half the patients had a dysmodal segment of colon on repeat manometry. That segment was resected at the time of colostomy or stoma closure. They reported that the defecation problem resolved in 10 cases. It's a little bit elusive what that means, but second study from Mass General Hospital, 19 patients, again, abnormal manometry, diverted with ileostomy, repeat testing. 74% of their patients were able to have continuity reestablished as part or a majority of the colon had regained function. 5 of these patients, motility was considered normal on repeat testing and they had their stoma closed. 9 of the patients required a segmental colon resection at the time of stoma closure, and satisfactory outcome was achieved in 95% of patients, patient-reported satisfaction. Given these barriers and gaps of knowledge that I've discussed, such as variable treatment modalities, lack of standardized definitions, inadequate long-term follow-up, small single series studies, the Pediatric Colorectal and Pelvic Learning Consortium was organized in 2016. This was financially supported by a gift from Primary Children's Foundation. It's a group of surgeons, gastroenterologists, other medical doctors around the country and internationally, focused on the care of children with colorectal disorders. We have a robust database that has been created. There are currently 5 sites within the U.S. that are contributing data to the database, with an additional 10 centers in the process of IRB approval to begin participating in our data collection process. We collaborated with the Data Coordinating Center at the University of Utah to develop a robust and detailed database. And they continue to work with us for database maintenance to try and sort out what's going on with these children. So there's many forms within the database. There's a history form, patient, medical surgical history, prenatal history. We collect any surgical procedures that have been performed, tests that have been performed, specifically motility testing. And then perhaps the most important part of this database is our follow-up visit forms. We have a very structured follow-up schedule and detailed follow-up reports that are collected so that we can begin to understand the long-term function in these children and the effect on their quality of life as well as their family's quality of life. Currently, there are over 1,200 patients in this registry, and roughly a third of them are children referred with functional constipation. So in summary, most children referred with severe functional constipation are considered candidates for high-dose stimulant laxative therapy, at least initially. The one exception to this may be a child who's actually never been toilet trained or a child that has a megarectum. Those 2 populations we will frequently just begin on enema therapy and attempt a laxative trial later. In children that fail stimulant laxatives, enemas can be highly effective. If they fail laxative and enema therapy, then additional testing should be performed to guide surgical therapy. And a step-up approach is taken to surgical intervention for management. Finally, temporary diversion may allow recovery of colonic function, allowing children to keep the colon. It's not totally useless, and allow recovery and improved life. I threw in this last slide. It's an algorithm that was recently published. It's in the handout for your reference. But this is an algorithm that we generally follow in our clinic. It helps us if we can kind of group these patients into these different categories, and helps guide some of our treatments for them. Thank you.
Any questions for our speakers?
So the enthusiasm about the biofeedback therapist is certainly of interest. What kind of patients are most likely to benefit from that, and what is the overall success rate for that approach?
Great question. So the patients who are most right now that we're referring to for biofeedback are patients that we identified dyssynergia as a major problem. So when they're straining and unable to defecate due to uncoordination of their pooping mechanism, the data that's something that we're very interested in looking at, actually, to see the patients that we're referring over, how many of them is it changing their management. We have a lot of anecdotal evidence so far that it's been fantastic, not just from retraining maybe the muscles, but also just she almost acts as a life coach and addresses the behavioral aspect. It's someone that they can meet with twice a week to cheer them along while they're working through their bowel management program. So we're hoping to get data and present it.
I saw nerve stimulator on that last slide way at the bottom. Is that part of the retraining?
So sacral nerve stimulation, just a little bit of the history, that was used in patients with spinal cord injury for neurogenic bladder, and one of the side effects that was noted was improvement in some of their constipation. Sacral nerve stimulators currently are only being used on in funded studies for implant. That is something that may come to us in the future. But right now, series are really small, and I don't think we quite have that figured out yet. 60 to 70% of the people that initially have a response with sacral nerve stimulator lose that response. And so I'm not sure where that fits in yet. Certainly it's a consideration if a patient has failed everything else or may be interested in sort of cutting-edge treatment.
Any other questions?
The paucity of long-term follow-up is certainly. The paucity of long-term follow-up data is certainly disconcerting, but nonetheless, having cared for a number of these patients in the long term, do you at least have some anecdotal impressions to share? What happens to these individuals when they reach adulthood?
You mean to take that? So, given the magnitude of this problem, it is surprising that there's not more literature out there in long-term follow-up and something to guide us. Anecdotally, I will tell you that most of the patients that reach the point where they need an appendicostomy for management continue to need that for years. We do have some teenagers that have been able to come off of appendicostomy onto a high-dose stimulant laxative program, but none that have been able to just stop any kind of treatment. And I would say that our experience kind of mimics the other series that I showed you. Maybe 1 in 5, 1 in 6 are able to do that. I can tell you that families are extremely happy once a child is successful on either laxative or enema therapy. They always want to know how long they have to do this. And I mean, the short answer is, I don't know. We're trying to figure it out. We do, in patients who are on enemas, if they have, assuming that they're strictly functional constipation child, they don't have anatomical problems leading to their constipation, then each year we perform a laxative trial if the patient and family want to see if they can come off their enema and onto a laxative therapy. But I don't know if that answers your question, but
As good as I'm likely to get.
Any last questions? Okay, grand rounds next week, multi-purpose room. Thank you.
nice job, bud.